Diabetes emergencies, DKA, and HHS. The priority concept we'll be talking about is glucose regulation, and the interrelated concepts include nutrition, tissue integrity, sensory perception, immunity, fluid and electrolyte balance, and acid-base balance. Proinsulin is secreted by and stored in the beta cells of the islets of Langerhans in the pancreas, and this is transformed by the liver into active insulin. Insulin will then attach to receptors on target cells where it will promote glucose transport into the cells through the cell membrane. So basically, what are we saying? Glucose regulation requires insulin to move glucose into many of the body tissues. The insulin basically is acting like a key to open up the locked cell membrane to allow glucose to enter the cell. Well, we have to have the glucose for energy, right? So a lack of insulin will prevent the body from using glucose for energy because it could not get into the cell. It will increase the amount of glucose that then is circulating in the blood vessels. It will disturb fluid and electrolyte balances. It leads to polyuria, polyphagia, and polydipsia. So what we're seeing here is excess glucose will cause an osmotic diuresis, and this leads to polyuria, which is the excessive urination. That will lead to dehydration, which causes polydipsia, which is excessive thirst. And because the cells are not receiving glucose, now we start seeing cell starvation occurring. This will trigger polyphagia, which is excessive hunger. And the client will remain in that metabolic starvation until insulin is available to remove or to move glucose into the cells. Now, since the body is not able to use the glucose for energy, it's got to get energy from somewhere. So it begins to break down fat and protein for energy. We see ketone bodies, which is an acidic byproduct of fat cell breakdown that are being released when the body uses fat for energy. This will lead to an acid-base imbalance of metabolic acidosis. The increased acid will then cause the brain to increase the rate and depth of respirations in an attempt to blow off that carbon dioxide, which is acidic, and the other acid. And we call this Kussmaul respirations. And then finally, with that fat breakdown, acetone is being exhaled. And this will cause a fruity odor to the breath. Smells a lot like juicy fruit gum. Dehydration will then lead to hemoconcentration, hypovolemia, poor tissue perfusion, and hypoxia. This leads to an increased lactic acid production, causing even more acidosis. The increased fluid loss also causes an excuse me. The increased fluid loss will also cause an excess loss of potassium, which leads to hypokalemia. However, in acidosis, potassium ions within the cells will be exchanged for hydrogen ions. So when we have DKA, the potassium is coming out of the cells and into the bloodstream. So now we have hyperkalemia. Diabetic ketoacidosis is going to be caused by an absence of insulin and the generation of ketoacids. Death can occur in up to 10% of these clients, even if they receive appropriate treatment. The symptoms they see in diabetic ketoacidosis is polyuria, polydipsia, and polyphagia. Ketosis Kussmaul respirations as the body attempts to correct the acidosis. The ketosis is due to the fat breakdown for energy. We have that fruity odor to the breath from the breakdown of fats for energy. Nausea and abdominal pain are from the acidosis. Dehydration from the increased diureses due to the increased osmolality of the blood because of hyperglycemia. Then we start seeing lethargy and coma. Those changes in the level of consciousness are due to that poor tissue perfusion and hypoxia. And we may also see shock. Diabetic ketoacidosis has a sudden onset. When we look at lab findings, our serum glucose is going to be greater than 300 milligrams per deciliter. We will see serum and urine ketones present. The serum pH, excuse me, will be less than 7.35. The serum bicarbonate will be less than 15 milliequivalents per liter, and BUN and creatinine are going to be elevated due to dehydration. So let's generate some solutions and start taking action. It will require blood glucose management. That blood glucose management is going to require obtaining blood glucose levels frequently until stable. We need to assess the airway, the level of consciousness, the hydration status, electrolytes, and blood glucose levels. We're going to monitor the vital signs every 15 minutes until stable. We need to monitor the urine output, the body temperature, and mental status hourly. And if a central venous access device is present, we should be monitoring central venous pressure every 30 minutes. All of these assessments and monitoring can be backed off to every 4 hours once the blood glucose has been stabilized with treatment. For the fluid and electrolyte management, we need to assess fluid and electrolyte balance. This will include looking at signs of dehydration or hypovolemia, which would include a loss of weight, thirst, decreased skin turgor, dry mucous membranes, and elevated urine-specific gravity, weak and rapid pulse, flat neck veins, increased body temperature, decreased central venous pressure, muscle weakness, postural hypotension, and cool, clammy skin. We need to administer intravenous hypotonic fluid therapy at a rate of 15 to 20 mLs per kilogram per hour for 1 hour. Then at a rate of 4 to 14 mLs per kilogram per hour after that initial bolus is in. When the blood glucose levels begin to reach 250 milligrams per deciliter, we will be changing the fluids to 5% dextrose in 1/2 normal saline to help prevent hypoglycemia and cerebral edema, which can occur if we drop that serum osmolarity too quickly. We should also be monitoring cardiac, kidney, and mental status for fluid volume overload, in addition to monitoring blood pressure, INO, and daily weights. And drug therapy will involve insulin therapy. We will be doing a continuous regular insulin IV infusion after we give a regular insulin IV bolus. When the client is able to take oral fluids and ketosis has stopped, then we can start giving insulin subcutaneously. DKA is considered resolved when the blood glucose is below 200 milligrams per deciliter. The bicarbonate level is higher than 18 milliequivalents per liter, and the serum pH is over 7.3. With insulin therapy, the correction of acidosis and volume expansion, it's going to decrease the serum potassium concentration, correcting DKA's mild to moderate hyperkalemia. But if the serum potassium levels fall below 5 milliequivalents per liter, we will need to administer potassium replacements. So it's important to assess for signs of hypokalemia and hyperkalemia in an EKG, but realize that hypokalemia is a common cause of death in DKA. Another medication we may administer would be bicarbonate, and this would be for severe acidosis, where the arterial pH is 7.0 or lower, or the serum bicarbonate level is less than 5 milliequivalents per liter. Things that we should be teaching our clients is a lot of these clients will experience DKA during sick days. So we need to teach them how to take care of themselves when they're not feeling well. They should be checking their blood sugar levels at least every 4 to 6 hours when they have anorexia, nausea, vomiting, or their blood sugar levels are over 250 milligrams per deciliter. They should be checking urine ketone levels when their blood glucose levels are at a level of 240 to 300 milligrams per deciliter. They should be drinking increased fluids, at least 2 liters a day, increasing that amount if infection is present. And if nausea is present, they should be drinking liquids that do contain glucose and electrolytes. If the client is unable to eat solid foods, they should be drinking fluids that have carbohydrates. They may need to take a rapid-acting or short-acting insulin or oral anti-diabetic agent based on their blood glucose levels. In other words, just because they may not be eating or drinking, they may still need to take insulin or their oral anti-diabetic agents. They should also be taught to contact the healthcare provider if they have persistent nausea, vomiting, diarrhea, and fever for more than 24 hours or illness that lasts longer than 1 to 2 days. If their blood glucose is over 250 milligrams per deciliter and does not respond to therapy. They have ketonuria for more than 24 hours, or they are unable to take food or fluids. The hyperglycemic hyperosmolar state is going to result from sustained osmotic diuresis, and this will lead to hyperglycemia. One of the big differences between DKA and HHS is with HHS, there is little to no breakdown of fat in the cells. So we are not seeing ketosis, and there are no ketones in the blood or the urine. There is enough insulin with HHS to prevent ketosis, but not hyperglycememia. And the glucose levels will be much higher with HHS than with DKA. These clients may have confusion to a coma. They may also experience seizures and reversible paralysis due to that high serum osmolarity over 350. Excuse me. HHS will occur more frequently in the older adult than other age groups that have type 2 diabetes mellitus, and they do not know that they have diabetes mellitus. The mortality rates are also higher, and they're as high as 16%. So how do we take care of these clients? Well, with fluid therapy, the first priority is to increase that blood volume. With shock or severe hypotension, we give normal saline. Otherwise, we'll give half normal saline. We will infuse it at a rate of 1 liter per hour until the central venous pressure or pulmonary capillary wedge pressure begins to rise, or the blood pressure and urine output is adequate. Then we will reduce that fluid rate to 100 to 200 mLs per hour. We need to monitor the body weight, the urine output, the kidney function, and the presence and absence of pulmonary congestion and jugular vein distension to help us determine the rate of that fluid infusion. And we should also assess hourly for signs of cerebral edema, such as abrupt changes in the mental status, abnormal neurological signs, and coma, including pupil size, shape, and reaction, or seizures. Continuing in therapy will consist of IV insulin only after the fluid volume is replaced. We'll start off with that initial IV bolus again, followed by a continuous IV insulin infusion, with the expected outcome of reducing the glucose to 50 to 70 milligrams per deciliter per hour. We should also be monitoring for hypokalemia, monitoring those serum electrolytes every 1 to 2 hours until stable, and monitoring the cardiac rhythm continuously. And then client teaching will be similar to minimize dehydration and prevent ketoacidosis. Excuse me once again. So now we have a 23-year-old client with a history of type 1 diabetes who is admitted to the emergency department with nausea and abdominal pain. His respiratory rate is 34 breaths per minute with deep breaths and a fruity smell to the breath. He's responsive but difficult to arouse. What does the nurse suspect is happening with this client? This is DKA. What serum glucose level would the nurse expect to see with this client? It's going to be over 300 milligrams per deciliter. The student nurse asks why the client is breathing so rapidly and deeply. What is the nurse's best response? Is it his serum pH is high and this is a compensatory mechanism? Is it his serum pH is low and this is a compensatory mechanism? Is it his serum potassium is high and this is a compensatory mechanism? Or is it his serum potassium is low and this is a compensatory mechanism? The correct answer is B. As ketone levels rise, the buffering capacity of the body is exceeded and the pH of the body will decrease, leading to metabolic acidosis. Kussmaul respirations, which are the very deep and rapid respirations, can cause respiratory alkalosis in its attempt to correct the acidosis by inhaling carbon dioxide or exhaling carbon dioxide. Sorry about that. Caught it too late to get it in. So in the emergency department, the client is diagnosed with diabetic ketoacidosis. What is the nurse's first priority for managing this condition? Is it airway assessment, administration of insulin, fluid and electrolyte correction, or administration of IV potassium? The correct answer is A. The first priority is airway management, rapidly followed by the administration of insulin, fluids, and correction of any electrolyte imbalances. 20 minutes later, the client is admitted to the ICU for DKA management. The client is receiving IV regular insulin with frequent finger sticks to check his glucose level. His potassium level is 2.5 and IV potassium supplements have been ordered. What assessment must the nurse make before giving the IV potassium? Is it a respiratory rate of less than 24 per minute, production of at least 30 mLs per hour of urine? Is it level of consciousness and orientation, or finger stick glucose of less than 200 milligrams per deciliter? The correct answer is B. Hypokalemia is a common cause of death in the treatment of DKA, but before giving IV potassium, we have to make sure that the client produces at least 30 mLs per hour of urine. 2 days later, the client has recovered and is preparing for discharge. His wife asks about what they can do to prevent this from happening again. What should the nurse teach the client and his wife? Select all that apply. Excuse me. Is it monitor glucose whenever the client is ill? Decrease fluid intake when nausea and vomiting occur? Watch for and report any illness lasting more than 1 to 2 days? Check blood glucose levels every 4 to 6 hours if anorexia, nausea, or vomiting is experienced? Or check urine ketones when blood glucose is greater than 300 milligrams per deciliter? The only incorrect answer is B. A nurse is teaching a group of clients about metabolic syndrome. Which assessment features are associated with the syndrome? Select all that apply. Is it male waist circumference of 44 inches? Fasting blood glucose of 66? Triglyceride level of 162? Blood pressure of 135/85? Or the client is taking blood pressure medication? Again, the only incorrect answer is B. When caring for a client having a hypoglycemic episode, the nurse knows which symptom requires immediate intervention. Is it hunger, confusion, headache, or tachycardia? The correct answer is B. We know that glucose is necessary for brain function, so confusion is a marker of severe hypoglycemia and requires immediate intervention. And final question. The nurse is teaching a client with type 1 diabetes about exercise. The nurse understands the client should avoid exercise during what time? During colder months, when serum glucose is less than 150, when ketones are present in the urine, when emotional stressors are high for the client. The correct answer is C. If we have ketones in the urine, then the client is burning fat for energy. So exercise should be avoided. That indicates that the current insulin levels are not adequate, and exercise is only going to elevate the blood glucose levels. Correct answer, once again, C.